Hello everyone, my name is Jessica and today I am presenting on the clinical case study of my patient LB. And to begin, I'd like to start with the primary disease, which is diabetes mellitus. A lot of us have extensive knowledge on the etiology and pathology of it, so I just wanted to cover a bit about the prevalence. According to the National Institute of Diabetes, Digestive and Kidney Disease, the NIDDKD, in the US alone, there are 30.3 million, or 9.4% of the population, as diabetic. 7.2 are undiagnosed cases, and 1.5 new cases of diabetes are found each year. Along with type 2 diabetes, they increase with age. So about 27% of the elderly in community care homes are diagnosed with diabetes. Symptoms include polydipsia, dysuria, retinopathy, neuropathy, foot ulcers, hypertension, obesity, gastroparesis, fatigue, and weight loss. This reflects in our patient of frequent thirst, urination, blurry vision, numbness and tingling in the hands and feet. These ulcers tend to be non-healing or slower at healing, which is a concern. And gastroparesis means that there's just slower motility in their stomach muscles, causing what feels like fullness, even though they might be hungry. For a diagnosis, we can do the A1C test or the glycated hemoglobin test. It has to be greater than or equal to 6.5%. A fasting glucose of blood sugars has to be less than 100 milligrams per deciliter, and the oral glucose tolerance test of about 140 to 199 milligrams per deciliter. For the secondary disease of this patient is chronic kidney disease. Kidney failure can cause diabetic neuropathy, hypertension, lupus, nephrotic syndrome, vomiting, insomnia, urinary incontinence, UTI, edema, altered mental status. Often they can be tested through blood urine tests, kidney biopsies, CT scans. And in the case of the patient today, they had end-stage renal disease, which is the last of the chronic disease states, where the kidney operates at 10 to 15% of normal function. And for these patients, they can often go for hemodialysis. So for our patient, she was a 66-year-old Caucasian female. Her social history included that she was married, lived at home with her husband. She had smoked 2 packs for 50 years, and she did have children as well. She was admitted for altered mental status, tachycardia, hypotension, and sepsis. She had a rather extensive past medical history. Earlier in the year, in August, she had a below-the-knee amputation on her left leg due to multiple symptoms of peripheral vascular disease, osteomyelitis, a non-healing chronic ulcer on her left foot. She had multiple comorbidities that included hypertension, hypothyroidism, type 2 diabetes, coronary artery disease, chronic heart failure. She had osteomyelitis, end-stage renal disease, and she was receiving hemodialysis 3 days a week, Monday, Wednesday, Friday, and a non-healing abdomen wound from a hernia repair 4 years ago. The patient's history also included MRSA bacteremia and C. diff infections. She had past surgical histories of a tubal ligation, cholecystectomy, a ventral hernia repair, creation arteriovenous fistula, and a left angioplasty and a portacath for hemodialysis. Currently, they had found that with sepsis, it was due to a mitral valve vegetation, endocarditis, a bacteremia. Her altered mental status was from a metabolic encephalopathy. Her right leg had needed to be amputated for a great toe necrosis from the diabetic foot ulcers. Her permacath was actually infected, which also furthered the sepsis, and she had type 2 diabetes and hypothyroidism. From her notes, it was seen that she needed the amputation. However, she was not in a state that would the surgeon suggest open heart surgery for the endocarditis. From the nutrition care process, her food intake was recorded about an average of 4% for 27 of the meals reported. A few of the meals weren't recorded, but it was very minimal intake. Speaking with the nurses and looking at the nurse's note, A lot of the times, the patient chose to be NPO and would be non-compliant with any of the PO intake, whether that would be food or medicine. I spoke with the ACP, and she also concurred that the patient was eating very minimally. The family stated that she would often have a few bites, but it would not be substantial enough. For nutrition-related ADLs, the left below the knee amputation, the metabolic encephalopathy, which would cause soft restraints at sometimes, the altered mental status required her to have assistance during meals. For the weights of her length of stay, she was admitted about 77.8, 77.9 kilograms. And as we've seen throughout her length of stay, there was a overall trending decrease. From the last weight we had recorded was about 63.6 kilograms. We did account for hemodialysis and thinking about other things that might have caused her weight to trend down, but with her state and she was not eating, there was about an 18% weight loss according to the weight history over a span of 17 days, which reflected in a 14.3 kilogram difference. From her medication prescription during her stay, we saw that she had a lot of antibiotics for her sepsis and her antihistamine, anticoagulants. She did have a fast-acting insulin, a probiotic, a hormone for hypothyroidism, and a lot of pain, opioids to control the pain, as well as a sodium chloride infusion to maintain fluid and electrolyte balance. For her height, she was 5'7". Her weight was about 171 pounds, and that put her BMI about 26.9 kilograms per meter squared, which had her in the overweight category. We did have to adjust her weight for a left BKA and then later for a right AKA, so her adjusted weight was 52.6 kilograms, or about 115 pounds. From my nutrition-focused physical findings, I found that because at the beginning of the admission, the patient was in and out of consciousness, the altered mental status, the shouting, she was not, her mental state was not there completely. Her extremities, there was slight depression in the temporalis and pectoralis muscles, and I did check with the left below knee amputation, and then later I did confirm that it was a right above the knee amputation, just in case there was any charting errors. And the dark circles, depression, loose skin under her eyes as well. From her estimated energy needs, there was, we calculated once at the beginning, and then once we had seen there was a decreasing trend in weight, we had recalculated again on November 8th. But to begin, we did an MSJ and used an activity factor of 1.3 to 1.5. And then later we adjusted from 1.3 to 1.6 just to help with wound healing and the extra energy needs that she would have. For her proteins, we did take an account of the hemodialysis, which would increase needs, as well as increasing needs for her full thickness wound and her amputations. So we did a 1.3 to 1.5, and then later a 1.3 to 1.6, which is about 101 grams to 116 grams, and then later 83 to 101 grams. For her fluids, we wanted to stick with the 1 milliliters per kcal, so about 1,700 milliliters, or we left some room for nephrology to follow. There was also the nutrition diagnosis, the inadequate oral intake related to altered mental status, decreased appetite, as evidenced by PO intake of less than 50%. This was during the initial visits when we had her screen for a length of stay as well as a diabetic education before we found that she had further complications that would arise. As we found that she had severe protein calorie malnutrition in the context of acute on chronic illness related to poor appetite, cognition impairment, as evidenced by a severe weight loss of 18% in 17 days and poor PO intake of an average of 5% for 17 days. We did put in a malnutrition note for the doctor to sign, but unfortunately he did not agree with our findings that she was malnourished. But I think what he had missed was the acute context of the illness, where she had not eaten at all for 17 days and was just not fit for extensive surgeries without proper nutrition. For interventions, we did have her on a consistent carbohydrate diet, and for her diabetes, and a mechanically altered for dysphagia. We had commercial beverages for oral nutrition supplements, a multivitamin, Nephrite, and we did put in nursing communications to help with meal setup, positioning the patient, and trying to encourage the patient to eat during meal times. And at the beginning, we did do a few diabetic diet educations with the patient and the spouse and family members in the room. For her diet orders, it did flop at the beginning between NPO and clear liquids. She was NPO when she was first admitted, and then on the 24th, she was advanced for clear liquid for 2 days. We did put in a supplement of Ensure Clear 3 times a day. On the 26th, she was NPO for a TEE, where they found the mitral valve vegetation in her heart. On the 27th through the 29th, she was placed on clear liquids with a supplement of Ensure 3 times a day, as well as Juven twice a day now. However, on the 29th, we noticed that she was beginning to not really eat as much. So as just in case they needed it, we had 2 feed recommendations in for Nepro at a growth rate of 45 milliliters per hour to provide 1,944 calories, 88 grams of protein, 783 milliliters of water, and 114% of RDIs. We gave them where to initiate and how much to advance, but we wanted to let them know that the patient was a refeeding risk, so they had to check phosphorus, potassium, magnesium for 3 days and to replete as needed with fluids and flushes per MD or nephrology. On the 29th through the 5th, she was advanced to a consistent carbohydrate puree. However, she still was not eating at this time. It was very minimal PO intake after speaking with the nurses, the care tech, and as well as family. We had kept the same 2 feed recommendations as above, but we also wanted to put in TPN recommendations because we felt that at this point it was necessary to have some form of nutrition. For TPN, we had a goal of 1750 kcals at a dosing rate of 77.8 kilograms. We wanted 110 grams of amino acids. We used 1.4. 282 grams of dextrose, 35 grams of fat. The GIR was 2.5. We had to keep an eye on that because of the diabetes. And when we had put in TPN rec, she was grossly inadequate PO intake for 10 days. We wanted to supplement with thiamine and the dextrose until the electrolytes stabled, titrate as electrolytes and blood glucose stable, and we had to caution with total volume during this refeeding period. If they wanted to use this TPN recommendation, the patient would need central line access. And we did keep the Nepro twice a day, and we suggested an appetite stimulant on the 1st. We had these both in for the patient and the family in case they wanted to continue with aggressive treatment. On the 6th, they were NPO for the right amputation above the knee. On the 7th and 8th, they were back on the consistent carbohydrate puree, and we recalculated the TPN and tube feeds recommendation as below. And we had the Nepro 3 times a day and the Nephrovite daily. From speaking with the nurses, the family, the care tech, she was not eating very much, but what she would do was take a sip of the Nepros throughout the day. However, it still wasn't substantial enough to make up for her needs as well. And below is where we have all the recalculated and adjusted tube feeds and TPN. For monitoring and evaluations, this was the goal progression. So it started with to reinitiate nutrition to meet at least 50% of estimated needs through PO intake within the next 3 to 5 days. This is when she was initially NPO. And then we had the goal to initiate alternative form of nutrition in the next 24 hours with ongoing care to prepare for surgery, because she had to have some form of nutrition just to help her better prepare. To meet at least 25 to 50% of estimated needs by PO intake over the next 2 to 3 days, and to consider an alternate source of nutrition should the patient fail to meet above. This goal was set when the son had returned from Japan overseas to help hopefully brighten the spirits and help the patient encourage to eat. They did see a brief moment where her mental status returned back to baseline, so they were hopeful that she would eat again soon. So we had suggested that if she would be able to medically feasible PO intake, then to encourage PO intake. However, we should also consider the alternate source of nutrition. And finally, our goal was to meet 50% of estimated needs within the next 2 to 4 days with the confines of the disease state from PO intake and oral nutrition. This was our last PES statement that we were able to see before the patient had discharged, hopefully in that she would have met her nutrition needs through PO intake, oro, and oral nutrition supplements. In the end, the patient did discharge to a long-term acute care hospital back home in her state of Georgia, and her diet was a consistent carbohydrate, 60 grams, and a pureed diet per, and we wanted to leave the consistency per a speech pathologist. We had suggested to continue Nepro for 3 times a day, Neprovite daily, Juven twice a day for at least 30 days post-discharge for all of the wound healing and the increased protein needs for hemodialysis. In the future, recommendations would include to incorporate diabetes education with the family and the patient as soon as they have been diagnosed with diabetes, to follow up with a outpatient dietitian, and we wanted to make sure that they understood that they had increased needs for wound healing as well as the hemodialysis, that the patient would need more protein. And then these were my references. I hope you guys enjoyed my case study.